According to the late actress Sophie Tucker, the secret to longevity is to keep breathing. Our precious lungs tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. We start breathing the moment we are born and our lungs keep working until the end. Their function is vital to our life and well-being. First, a look at this week's Prairie Doc quiz question. It is multiple choice tonight. Smoking is a causative factor in all of the following problems except A, lung cancer, B, COPD or emphysema, C, asthma, or D, heart attack and stroke. Viewers who call in the correct answer will be entered into a drawing to win a copy of the book, The Picture of Health. Each of Dr. Holmes' essays, originally written for On Call with the Prairie Doc, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We will announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. We answer your questions about breathing and our lungs as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight in the studio is Dr. Michael Pietila of the Yankton Medical Clinic. Welcome, Dr. Pietila, back to the show.
Thanks.
Yeah, so remind us about your background and what you do day to day as a pulmonary physician.
Sure. So I work at the Yankton Medical Clinic and Avera Sacred Heart Hospital in Yankton, originally from Lake Norden, South Dakota, Hamlin High School and South Dakota State. I've got to get that in there each and every time. Go Jacks. And then I went to the University of South Dakota School of Medicine and on to the Mayo Clinic and did internal medicine residency, pulmonary, critical care, and sleep medicine fellowship. Been in Yankton now 15 years. I do pulmonary medicine outpatient, which is taking care of patients with lung conditions. And then also a medical director of the intensive care unit at Sacred Heart Hospital, where we care for the sickest patients in the hospital. I'm an associate professor with the School of Medicine, so I teach med students as well.
Yeah, great. Before we start taking the questions, and I'm sure there'll be no shortage, let's do like a 5-minute update on COVID. We haven't talked about COVID on the show. I'm worried about it. I'm thinking about it when I go to bed every night right now because our numbers have been concerning. So what are we seeing in South Dakota and what are your thoughts about what we need to do?
So I think a table is going to go up that shows how our numbers are rapidly increasing most recently. And so this graph actually comes from a retired internist out in Rapid City who's done a great job of compiling some numbers. And essentially, if you look at this graph, in the springtime as the cases were starting to rise, we decided to flatten the curve by closing schools, closing businesses, practicing physical distancing. At that time we didn't recommend masks because number one, there weren't enough available, and number two, there wasn't a lot of data to say that masks helped. But you can see the curve flatten and coming into the summer actually dipped down a little bit. And then we decided, for reasons not responsible for public health, to open everything up again. And I get that, you know, it's a tough position to be in when our economy is in a downturn and people aren't able to work, they're getting laid off. But in a pandemic, if you don't practice the mitigation strategies, this is what happens. And so now we're seeing record numbers of cases on a daily basis, which then are followed a few weeks later by record numbers of hospitalizations, which then you can safely assume, since we don't have an effective treatment, that deaths will rise. And so what do we know now works to help prevent that? Well, one is physical distancing, you know, keeping space between you and others in a room. And then if you can't do that, to wear a mask. The data is there now to show that communities or countries where people mask up, they reduce transmission of the virus, which therefore reduces the number of people infected, which subsequently reduces those who are hospitalized and subsequently those who might die from it. And so I think now more than ever, it's important to reiterate the importance of social or physical distancing, using other ways to communicate instead of sitting close in large groups indoors, and the wearing of masks.
Yeah. And as I think about this just personally, and I talk to my patients in clinic about that, we're thinking about the holidays coming up. You know, summer is officially over. There's snow on the ground here in Brookings, and so outdoor, you know, seeing your friends outdoors is probably not going to be easy to do for a while. I feel it's going to be a tough winter for all of us, but we're really going to have to keep our circles small and you know, probably not be doing the holiday parties like we've always done.
No, I think we see what super spreader events are, and we know right now the rise in cases is primarily that age group 20 to 40 who are not practicing the physical distancing and not wearing masks. And you know, you might say, well, they don't get that sick. Well, some do. But they spread it to other individuals, and our children, it's going to get into the schools if we're not cautious, and then they'll spread it to their grandparents, and then that's when the mortality rates and the number of deaths unnecessarily rise. There's sometimes this misconception about something called herd immunity, and I think that's something our leaders are trying to get to the point of where enough people get it that then it doesn't pass on from others, but we'd have to get to at least 60% of people with the virus. We're nowhere near that. We're maybe around 10.
And that's not acceptable, right? I mean, the number of deaths that would lead to.
The collateral damage would be unacceptable. And so the idea of herd immunity, especially without a safe and effective vaccine, which we're not guaranteed to have at all, is a false one. So again, I can't reiterate enough. If you're going to do Thanksgiving, do your family, your core group, and then set up a Zoom or a FaceTime with the parents or with the grandparents or cousins or whatever else, and you know, make it as memorable as you can, recognizing that getting together in large groups is only going to allow the virus to spread. Thanks.
Well, we may come back to COVID. We may get questions on it, but why don't we start taking some questions from our callers? We have one question. What do the experts think is the most effective way to decrease smoking among adults? We'll talk more about that in our roll-in later, but you were just mentioning some behavioral strategies and some applications that might be helpful.
So the number one thing is to educate our children to never start smoking, right?
So, or vaping for that matter.
Yeah, or vaping, right? So that's the number one thing. But once you've started smoking, the best way to quit is a multifaceted approach. Number one, you have to make a commitment to it. It can't be because your spouse wants you to quit or your doctor. You have to want to quit for the benefit of yourself. Once you want to quit, then you make a plan, and the quit line's a nice way to do that. There's apps out there, or websites. One of the newer ones is icanquit.com, and they help you develop a plan. And then you recognize what triggers there are that lead you to smoking. You help your nicotine withdrawal by getting some nicotine replacement, patches plus lozenges or gums. And then consider medicines like Chantix or Zyban, which can be very beneficial in the right patient population to help them reduce their smoking. But the key is you have to commit to it yourself. You can't be forced into it.
And I tell my patients, I think accountability is good. So part of that planning has to include, you know, talking to your family about it. If you're quitting in secret, it's unlikely to be successful. Good. My grandmother got pneumonia and died, says one of our viewers. Why is a common infection still so deadly? That's a great question.
Right, it is. And so pneumonia just means an infection of the lungs. So sometimes I think people get confused that, well, I got the pneumonia vaccine, but that's just for Streptococcus pneumoniae. Pneumonia. So that's one bacteria that causes pneumonia. Now it's a bunch of different types of that bacteria, but that's only one. There's hundreds of other causes of pneumonia, and it's a very fatal disease. You know, if you're older or if you have other health problems, I know there was this data out there about COVID that, well, 94% of people had comorbidities or had other medical illnesses.
But
well,
really,
almost everyone
does. Most American adults.
Correct. No one just
age, right?
dies one day perfectly healthy. We all die because of our complications of our chronic medical problems, whether it's diabetes or obesity or high blood pressure or whatever else. So that's a misconception. But pneumonia is deadly because we depend upon our lungs to get oxygen, which our body depends upon. And the pneumonia affects our lungs in a way that impacts our ability to get oxygen to the rest of our organs. And so it's a deadly disease, and it always will be.
Right. And so bacterial pneumonia we can treat with antibiotics, though sometimes in severe disease that's not enough. But there's also viral pneumonias, influenza, COVID would be a great example of viral causes of pneumonia, which can also be very deadly.
Yeah, and when we're elderly, and that a number doesn't matter. That varies from, depends upon your genetics and your other health problems. But we die from something, and pneumonia is often that cause. And so, so it's not like it's rare, and it never will be. It'll always be one of the more common causes of death.
Yeah. Okay. Do you think we're likely to see more lung disease after the fires on the West Coast? Let's talk about those environmental things that might cause lung disease.
Sure. So those fires contribute to an increase in particulate matter, just a fancy word for dust particles in the air. And they do reduce the air quality, that's proven based upon measurements of air quality. But it doesn't necessarily correlate with an increased number of respiratory illnesses when you really look at the epidemiologic data. Now, anecdotally, I feel like I saw more of my asthma and COPD patients struggling this fall, on those hazy days, but I can't say scientifically that it's the cause. But air quality matters. And so forest fires don't help with air quality.
Yeah, good. How likely is it for a 12-year-old to grow out of asthma? He's doing well on his pulmonary function test lately and is on Advair and Singulair and takes albuterol as needed.
So the term grow out of asthma is a little bit of a misnomer. Once you're diagnosed accurately with asthma, sometimes you're labeled with asthma when you don't really have it. But if you're accurately diagnosed with asthma, you'll have it the rest of your life. It's just a matter of controlling the symptoms. And you might not need anything for control of your symptoms, especially if your triggers were something that you no longer experience exposure to. Other times you might go years without problems, and then all of a sudden you've got this cough and this shortness of breath, and you're waking up at night feeling like, I just can't get enough air, and it's your asthma. And so it's time then to step into therapy again. But it would be important for for mom and the 12-year-old to visit with their doctor and say, boy, he's really doing good. Can we maybe take away the Singulair or step down from Advair to just an inhaled steroid? That's what we're doing in asthma all the time. What I tell my patients is you'll have it the rest of your life. We want to manage it. Don't accept symptoms. We can control it. But we don't want you on too much medicine either. And so you're always reassessing asthma patients.
Good. A 47-year-old with bad lungs has trouble breathing and it hurts to be around smoke. Is avoiding smoke as best as possible, but wondering if there's any other remedy. And that might be hard to answer without a little more information.
So that sounds like the type of person who, if he hasn't had a pulmonary function test or seen a pulmonologist, he or she would benefit. 47's young to have serious lung disease. It's not that I haven't seen COPD, but 47 could be something else. That needs to be looked at. So my advice would be get into a pulmonologist, have a pulmonary function test, which we're going to have a little vignette about that shortly. That would be the key there.
We wouldn't expect that in a 47-year-old non-smoker who doesn't have history of asthma per se. So, well, let's go to that. An important part of gauging lung health are the pulmonary function tests that show how well your lungs are working. Prairie Doc reporter Carter Schmidt takes you to the Brookings Health System to find out more about them.
A pulmonary function test, or PFT, helps diagnose certain types of lung disease, such as asthma, bronchitis, and emphysema.
It's done through several different maneuvers, the main one being a forced vital capacity, and then we do some other tests to like a DLCO, or diffusion of lung of carbon monoxide, and then we do plethysmography. So several different maneuvers, and again, it's patient effort, and it's not necessarily patient dependent, but they need to give maximum effort to get good qualitative results.
Maximum effort could mean some intense coaching.
Keep blowing. I do that because I'm trying to kick in that response, that fight or flight type of response, to get that quick, fast reaction, and for them just to give me everything they got.
Big breath in.
it's very important because when you give maximum effort during these tests, we show the consistency, and we can actually see how your lungs really work. If there is variability, it doesn't really show, or it doesn't demonstrate how your lungs really are. So effort is everything for this test.
The test is performed to see where a patient's lung health is right now or after recovering from an illness.
Usually you want to do this in what we call a chronic stable state. So you don't want to do it when you're in acute phase, like you are actively sick. That would really just show how your lungs are acting when they're sick. And we want to find out what your lungs are when they're healthy in your healthy state.
And to keep your lungs healthy, you should get plenty of exercise and keep your lungs free of dust and other particles. But there is one thing that is most important.
No smoking. Don't smoke. I preach don't smoke. In fact, if somebody says they smoke, and my first joke to them always is, so you want to quit, right? Is that what you told me? And then I go over to things like South Dakota Quit Line, and try to find resources that are out there that I know of and what their things are.
We saw Derek mention the Quit Line, which we'll find out more about later in the program. Dr. Pietila, national studies have shown that even just brief advice to patients about quitting can improve your chances of cessation. Have you found that to be the case in your experience?
Yeah. So I think, for instance, I'll have a patient who the nurse will come out and report why they're there to see me, and I'll say, did you ask about smoking? And the nurse will say, yeah. And he said, don't talk to me about that. And so I'll still make a point to mention to the patient the importance of smoking cessation. Well, I'm not ready to quit. And I'll say, that's fine. And I'm not asking you to quit, but I'm asking you to think about quitting. So contemplation is the first step in making an attempt. So it's worth it, even if they're seeing you for a non-related problem.
Plant the seed,
ask
right? Yeah.
about whether they're smoking or not.
Yeah, and that's why I tell students in my clinic, you never, you sometimes you get lucky and you catch people on the right day and they wouldn't have told you otherwise. So we'll get back to some questions. We have a man that's wondering if dental devices can help sleep apnea.
Yeah, so sleep apnea, a very common medical problem, much more common than people realize, and can be associated with not only poor sleep and daytime fatigue or sleepiness, but worsening of certain other medical problems. And a well-designed oral appliance, especially mandibular advancement devices, which can be designed by dentists who have experience with mandibular advancement devices, can be very effective in moderate and mild sleep apnea. In severe disease, they're not proven to be as effective. And now CPAP is still the most proven treatment, wearing the mask at night, which it's very tolerable for most patients, and again, highly effective. And so even those patients who have failed CPAP in the past, there have been great advancements, and I encourage them to reconsider trying it.
Yeah, a lot more different mask choices and things like that. I think people are surprised when they tried and failed 20 years ago.
Right, it's way better now.
Yeah, good. We have a 69-year-old man who has COPD, and he's curious to know if there is any upcoming research that might give relief to COPD patients. Are there new therapies for COPD?
So there are evolving therapies for COPD, and it again depends upon the severity of his lung disease. So it would be helpful for me to know and what he's on for maintenance inhaled therapies. We know we now have long-acting bronchodilators, two different classes of those. Potentially steroids, they have a limited role in managing COPD. And then of course vaccinations are important. It's critical for COPD patients to get their pneumonia vaccines and their flu vaccines. Then there are some interventions like endobronchial valves that can be placed, or surgical procedures. Sometimes patients ask me about stem cells, and there's research on true stem cells, but the stuff you see out there now from like these National Lung Institute, that's not proven to be effective, hence the reason insurance doesn't cover it, and you have to travel and pay cash. So stem cells at this point are not of any benefit. But there are lots of good inhaled medications or nebulized medications, so if he's not seeing a pulmonologist, he needs to do that.
Yeah, good. Amanda's wondering how radon affects the lungs and body as a whole. something about radon test of 7 in his home.
Yeah, so radon is an inert gas that settles into the lower levels of our homes and into the soil. And when it comes to diseases that we know radon are associated with, lung cancer is the one. And it's not common. In fact, it's quite rare, but it's the second most common cause after exposure to cigarette smoke, whether it's primary or secondary. So cigarette smoke by far the biggest risk factor for lung cancer. I mean, so far it's not comparable to anything else, but radon would be second. So if you have a home with a basement, especially if you live in an area where radon levels are known to be high, which South Dakota, northeast Nebraska, where my practice in Yankton is the case, you should have it tested. And if it's a certain level, which I can't tell you what that is, it should be mitigated, mitigation system to get that ventilated out of your basement.
Is the only way to know to get someone to come there and get it tested? There's not a way to look that up on the internet based on your location?
There isn't a way to know definitively. Just certain areas you can Google what are high radon areas, but the way to do it is to get it tested and then have them.
Because there's some variability even within a single community, right? Okay. A Vermilion woman is wondering about your thoughts on a Zephyr valve implant for people with severe COPD. Is that something that you were just talking about?
So that's what I was just mentioning. So COPD affects the top part of our lungs more than the bottom. And what happens when it affects the top part of our lungs is our lungs get too large. They hyperinflate. And that too large a lung can't take in the air like the right size lung can. It sounds funny, but because it's too big, the diaphragm can't move like it's supposed to. So you can take these valves, and they're one-way valves, so they drain the air out of that ineffective lung, shrinking the lung up to allow more room for the diaphragm to get more air in. So each breath is a bigger breath. So if that person is on maximal therapy for COPD, has predominantly upper lobe disease, which most do, that'd be worth a referral to someone who does endobronchial valves.
Interesting. A Sioux Falls woman is wondering what your opinions are on the Trilogy ventilator for at-home treatment of COPD, another kind of new device.
So a Trilogy is going to target a certain minute ventilation. That's just termed to make sure you're breathing enough. And as we know in COPD, because of that hyperinflation and their diaphragm not moving as much, they depend upon accessory muscles. And when we sleep, our accessory muscles paralyze, and we depend only on our diaphragm. And so sleep aggravates hypoventilation in patients with severe COPD. So getting them on a Trilogy device, which is really a non-invasive positive pressure ventilator. It's not CPAP because it's actually giving certain pressures targeting a certain minute ventilation and respiratory rate, can bring down their carbon dioxide levels and improve their quality of sleep and therefore their overall quality of life. So it's actually a really good treatment for patients with really severe COPD who have hypercapnia, high carbon dioxide.
Okay, good. We'll get to some COVID-related questions. What's better, a cloth or a paper mask?
All right,
Do we know?
That reminds me, I wanted to say thank you to all the healthcare providers who are out there taking care of these COVID patients. And I don't just mean doctors and nurses, I mean our dietary staff, our housekeepers, our patient care technicians. It's going to get more stressful. We'll stay together. Don't get frustrated if you can help it, but I wanted to say that. So cloth mask or a surgical mask. So masks of those types, the types that you see us wearing, not in the operating room, protect others from your secretions. So we wear surgical masks. I'm not talking the respirators, N95s, but the surgical masks in procedures like you've got there. That type of surgical mask in procedures, because we don't want our secretions getting on the patients. They don't protect us necessarily from other particles, right? Wearing a mask is about protecting those around you. Cloth masks do the same thing. If you think about droplets, water particles, they block those water particles, saliva, from getting on someone else or on other surfaces. So it's not going to protect you from aerosolized viruses, but it'll protect you from exposing others. And we now have data, 6 months into this pandemic, that shows they are effective at reducing transmission. So one's not necessarily more effective than the other.
Right.
Just
Mask is good.
Just important to wear one.
Yeah. A woman asked if zinc and vitamin D work well for the virus, and if so, what dose of vitamin D?
What's your comment on this? So you treat a lot of vitamin D deficiency, I'm sure.
Yeah.
Well, maybe not treat it, but you're aware of it.
Right. And I think vitamin D as a whole probably got credit for a lot more than it did over the last 10 to 20 years, and it hasn't panned out that in various health conditions, specific Warvig, it's worked well. So I'm going to be a latecomer to buy that zinc or vitamin D is highly effective.
And so I'm with you. I think most of us are vitamin D deficient, especially in the winter months in the upper Midwest, but I don't think it has a lot of clinical impact.
Right.
I really don't.
Yeah.
I mean, there's been lots of different things saying, oh, vitamin D is the key to your bowel problems or your fatigue. It can help with bone health for sure, right? Fracture healing and things, it's been shown to be beneficial.
Yeah.
Is it going to boost your immune system? There's no evidence,
Right.
no scientific evidence to say it's going to boost it. Is it going to harm you? It's fat soluble, so it stays in your body. So it's not going to just go out in your urine like vitamin C will
Right.
or zinc will. And so it's probably not helpful,
Yeah.
especially as it pertains to COVID. Same with zinc. Zinc's been promoted for all viral illnesses, and some people swear by it. But again, if you look at the science,
Right.
it's not there. So I wouldn't recommend counting on vitamin D or zinc to be the key with COVID.
Yeah. A man says he has read COVID-19 can cause long-term lung damage. Have you had any patients that that's resulted in? And we're definitely getting a lot of anecdote, at least, about these sort of long-termers, be it with lung symptoms or just general fatigue and exercise intolerance. What do we know about that?
Yeah, so there definitely are cases of patients who seem to have long-term sequelae, long-term consequences of COVID infection, some of them not having had severe disease. And what does that mean? I don't know yet.
Yeah.
The worst cases of COVID, the ones that are dying, are getting what's called ARDS, acute respiratory distress syndrome, which is a brisk inflammatory response in the lungs. Some people have called it cytokine storm. Really, cytokine release syndrome is a better way to define it. And that does oftentimes cause permanent damage to the lungs. And so you might have a patient who's otherwise perfectly healthy, has normal lungs, who gets bad ARDS, is in the hospital, maybe on the ventilator for 2, 3, 4 weeks. That damages your lungs too. A ventilator is not a treatment. It's a way to bridge to an outcome.
Right.
Going on a ventilator is not a treatment. It's just a way to wait and see what's going to happen. You never want to put someone on a ventilator unless you have to. And they can get permanent injury to their lungs and end up stuck on oxygen the rest of their lives. I have a gentleman who's in his late 50s, perfectly healthy, working full time, and now he's chronically on oxygen and will be for however long he lives. So it's not just the death toll that matters in COVID-19.
Yeah.
There are potential other complications that you live with the rest.
And a lot of people, if they spend time in the ICU, especially with something like ARDS, but for any reason, take a long time to return to their prior level of functioning just because of muscle loss and those kind of things too, right?
It's you want to avoid ever having critical illness because the consequences are real and they're almost always present.
Yeah. But the sort of longer term outcomes of COVID, I think we're going to learn more about, but it's probably real. Yeah. A woman from Gregory is wondering if rheumatoid pulmonary fibrosis is hereditary.
So rheumatoid arthritis, as you're familiar, is an inflammatory disease that affects joints primarily, but it can affect almost any organ in the body, including the lungs. And it can affect the lungs in a multitude of different ways. So rheumatoid arthritis alone, it's clearly hereditary, right? There's clearly an association for genetics in rheumatoid. I'm not aware of a direct link between rheumatoid-associated lung disease and genetics. It's really about controlling the rheumatoid. That's how you treat rheumatoid-associated lung disease, is you control the rheumatoid with the disease-modifying agent of choice. So rheumatoid is associated with hereditary factors. I'm not certain on the lung disease part.
Sure. Can asthma symptoms decrease or disappear to the point of no longer needing treatment?
Yeah, absolutely. So as again, I tell my patients, you have asthma and you always will, but you may not need to treat it. But recognize if you're coughing or short of breath, that's your asthma. Too many times patients accept because I have asthma, it's okay, I cough and I'm short of breath. Well, we can treat that. You don't have to suffer with that.
Right. Good. The South Dakota Quit Line has one of the highest success rates in the nation. More than 38% who have used the service have kicked their habit. On-call reporter Tori Burnt spoke with the Quit Line coordinator.
The South Dakota Quit Line is a free resource available for any South Dakotan to utilize, and that's for anyone over the age of 13 who has either quit using tobacco in the past 30 days or is wanting to quit tobacco right now. So it's available for smokeless tobacco, so like the chew tobacco for people who smoke cigarettes, and also is available for e-cigarette users. So that's a new addition that we deemed. So if someone only uses e-cigarettes, they would also be eligible to use the Quit Line. And it's a service that is free, so we always like to promote that. We've realized that throughout time, we've become maybe a little bit numb to communicating that messaging to the public. And we've heard from people, oh, well, I thought I had to pay to do that. And it is something that is free. So we want to make sure we're always communicating the service itself is free. And if someone enrolls in it, the option for the nicotine replacement therapies as well as medication is also free. So that's a huge bonus. The services that we offer through the South Dakota Quit Line, we have a variety of options. So a person can call to enroll in the South Dakota Quit Line. And the number for that is 1-866-SD-QUITS. And they can call and speak with a coach who can get them enrolled in the program. They can also just call the Quit Line if they have a question to ask about the program itself. And so the phone service option is the coaching service, and they can get enrolled in that. And they would then be eligible to receive up to 12 coaching sessions. And if a person is enrolled in the phone coaching sessions, then they are also eligible to receive up to 12 weeks of a nicotine replacement therapy. And what we offer for nicotine replacement therapies are patch, gum, or lozenges. And then they would also have the option, if they don't want to do the NRT option, and they can talk it through, that it sounds like with their coach that the better option might be the medication. We also have prescription Zyban available for the Quit Line. And again, that would be up to 12 weeks of offering of that medication, as long as they're participating in the phone coaching service. And then we also have a feature called the Kickstart Kit, and that is a perfect option for someone who's maybe like, I don't really know if I want to call and talk to someone quite yet, or for someone who just really wants to do this on their own. And the Kickstart Kit option, people can go onto our website and enroll right there. And that's where they would just enter in their information, select that they're interested in receiving the Kickstart Kit option. And what that means is they would be eligible to receive up to 4 weeks of nicotine replacement therapy of their choice. I believe when they log in, it's like you can select up to 4 or you can select 2 weeks. If they select the 2-week option, they get that sent directly to them with a self-help quit guide. And if they select the up to 4 weeks option, what they will have to do is just have like one quick check-in call with the Quit Line to see how that service option is working for them. So I could go on and on because we have other service options too.
Great information from the Quit Line. We've got a lot more questions to answer, so let's get to it. What is sigh breathing, and is it anything to be concerned about?
So sighs are normal and necessary. Actually, as we breathe, we often don't fill all of our lung, and so we get a little bit of what's called atelectasis or collapse. And so taking a sighing respiration really fills those lungs up and helps to capture that portion of the lung that's not getting well aerated. So if someone's sighing frequently, not just because they're frustrated with someone else, it might be because they're not taking large enough breaths at baseline. If they're obese or if they have muscle weakness, it could be an indication sometimes of someone who's developing like an ALS, who is having trouble ventilating. Their lungs are restricted by neuromuscular weakness. They might have to sigh more often. So if that's a concern, it's worth mentioning it to the doctor. But it's normal to sigh. In fact, it's good for you to sigh.
Yeah, everyone does it.
Yep.
A man from Rutland is taking Trelegy, not Trilogy, and I will say that I'm a little angry that these new things, both for COPD, had such similar names. Trelegy, an inhaler in the morning, and is wondering if that's that's right, or should it be taken at night?
It makes no difference
Yeah.
with Trelegy. So Trelegy is an ultra long-acting inhaler. It has an inhaled steroid, a long-acting muscarinic antagonist, and a long-acting beta agonist. That's just to say an anti-inflammatory, 2 bronchodilators. Doesn't matter when you take it. You can take it in the morning, you can take it in the evening. It's consistent and effective for 24 hours. So what's ever most convenient for the patient.
Yeah, whatever you can be the most consistent.
Just make sure and
is the
rinse
right
your
thing to
mouth
do.
after, right?
Yeah, good. A Yankton viewer is wondering if the carbon dioxide breathed in from wearing a mask is going to lead to an increase in lung problems.
It will not. So a cloth mask or a surgical mask will not inhibit ventilation or cause low oxygen or high carbon dioxide. And you don't rebreathe your air when you're wearing a cloth mask or a surgical mask. So this myth that you might have heard out there that wearing masks is harmful, or if you have the virus and you wear a mask, you'll rebreathe the virus. It's not how it works. Now, patients who have restrictive lung disease, who have COPD, those respirators, those can cause problems. The tight N95 masks, they can reduce ventilation, and that's why we test people before we approve them at a place of business, for instance, that requires a respirator, an N95 or above. You've got to have adequate lung function for those. But cloth masks, surgical masks, perfectly safe.
Good. A man from Sioux Falls is wondering if there's any correlation between good nutrition and lung health.
Yeah, so it's critical. You know, one of the most worrisome signs in a patient with chronic lung disease is when they start to lose weight, because your metabolic rate's actually increased when you have chronic lung disease. Every minute you're burning more calories than someone who doesn't. And so having a healthy, balanced diet is key in patients with chronic lung disease.
Yeah, I've had a couple patients that I can recall that came in and their complaint was abnormal weight loss. They had lost, 20, 30 pounds, and it was a new diagnosis of lung disease as opposed to the other things that we
I've
kind
seen
of
it
think of.
more times than I care to admit.
Yeah, good. A former diver was diagnosed with tracheobronchopathia osteochondroplastica, or TO, after a car accident, and is wondering if there are any advances to identifying the cause and treatment since 2015. That's a specific question,
Right.
doctor.
I'm no expert in that area. It's usually found incidentally on an imaging study. So I'm guessing he had the car accident.
Right,
They did a
that makes
CT
sense.
of his chest, abdomen, and pelvis to look for consequences of the trauma, and they saw the changes in the airway that are consistent with the bronchiomalacia. It's usually a genetic thing, and so it's been that way all of your life. And oftentimes you're not aware you have it until you try to do something that might stress your lungs, or you find it incidentally on an imaging study. There are some from bronchiomalacia, which means too narrow of an airway. Okay, it means your breathing tubes are too small. There are some stenting procedures and things that have been offered for patients, but that's out of my area of expertise. So that'd be someone who I'd refer on to a center like the Mayo Clinic.
If this patient was symptomatic.
Symptomatic
whereas
is what's
if
most
he doesn't
important.
have symptoms,
Correct.
then there's no reason
if
to
it was
pursue that.
found totally incidentally because of the CT scan, then just ignore it.
Yeah, good. A 73-year-old hasn't smoked, but lived with parents who did for 17 years. Are there any chances that person will develop problems at this stage?
It's not zero, right? It's not zero, but the likelihood that exposure during childhood would lead to chronic lung disease at their current age is low. Now, they could have lung disease from something else.
Sure.
So if they're having symptoms of shortness of breath or cough, visit with their doctor about that. It could be occupational, it could be a medicine they're taking. So it's worth at least mentioning it to their doc. But I wouldn't go to the lung specialist alone just because I was exposed to cigarette smoke from home.
Right. That's a long lag time. It would be kind of
long lag time.
an unlikely story. Good. A Lennox man asked if having bronchitis once can increase a person's chance of getting it a second time. Are there long-term complications that can arise from having bronchitis?
Yeah, so recurrent bronchitis is a sign of chronic lung disease. It's part of the definition of COPD. A single episode of bronchitis is unlikely to increase your risk for more episodes of bronchitis, unless, of course, you have some other underlying structural lung disease, or you're a smoker. That's a sign of airway damage and future complications. But a single episode of bronchitis in the short term may result in some increased inflammation and risk, but long term a single episode shouldn't be harmful.
Right. Right. And bronchitis is one of those things that in primary care, I think we're doing things differently now than we maybe did before we were good antibiotic stewards. We know that most cases of acute bronchitis are viral in nature.
Absolutely.
And so it's not uncommon, and you can get it with healthy lungs.
When you get the common cold, you can have bronchial symptoms, and that's bronchitis.
Right.
Doesn't mean you need an antibiotic.
Good. A viewer on Facebook has an oxygen sensor at home. At what level of oxygen saturation drop should she seek a doctor's help?
So
Let's
it
talk
sounds
about
like
oxygenation,
right?
yeah.
So if she's got an oximeter, it sounds like she should have some chronic lung disease. So that's the big difference.
Right.
For those of us who don't have any chronic lung disease, our oxygen saturation really shouldn't be below 94 ever. It shouldn't be. Okay. Doesn't mean if it is that you're in big trouble, but 94.
Right.
But if you have chronic lung disease, you can tolerate low oxygen. I mean, some of my patients feel fine with a SAT at 80%.
Yeah.
And for a doc who doesn't do pulmonology, if their patient had a SAT of 80, they'd be pretty nervous. But I see that not uncommonly.
Right.
And so what's normal is 89 or above for chronic lung disease, 94 and above for no lung disease. But some chronic lung patients do just fine with SATs in the 80s. And so it's not about what the number's showing her, it's about her symptoms. So if she feels short of breath, and that number is low, then that's a problem. If she feels fine and she's just checking it for her own information, that number's probably not significant.
Sure. And a counterpoint to that is, like, when do you prescribe oxygen for patients?
Yeah.
So when do patients with chronic lung disease need to have oxygen at home?
So it varies again from patient to patient, right? The data would suggest that if your oxygen saturation at rest on room air is less than 89%, that if we put you on oxygen, you'll have fewer complications and live longer. Now that doesn't mean each individual, so it doesn't mean you have to be on oxygen, but studies would indicate that most patients would benefit. So room air, resting, 89 or below 89%. So then you have that patient who's 92, 93 at rest. You get them up and walk them, they drop to 85. They're very short of breath. You put them on oxygen, get them up above 90, and they say, hey, I'm less short of breath when I walk. They should be on oxygen. What I'm most frustrated by is I'll have a patient whose room air SAT's 91, they've got end-stage disease or cancer, and they're short of breath, and we put them on oxygen, and it helps them. Well, Medicare doesn't want to pay for oxygen unless the SAT's less than 89% based on those studies, but that's not proper.
That's not the patient that was being
it's helping
studied in,
the patient. So
Yeah.
again, the best data is for that person sitting, resting, less than 89%. Oxygen reduces mortality and improves their quality of life.
Good. And when it comes to oxygen sensing in COVID, because that's something that we're doing, if people are high risk, but they're well when we see them at first, it might be a prudent thing to do to have them use an oximeter at home. What would be signs that you would say, you should come back to the hospital?
Yeah, so the data, so again, the patients who do the most poorly are the ones who get pneumonia and potentially ARDS.
Right.
And that's best detected by their symptom, shortness of breath, right? The majority of COVID patients really have minimal symptoms.
Right.
But if you get COVID and now you develop shortness of breath, and it's usually about 4 or 5 days into the illness, you're doing okay, and then all of a sudden, day 4 or 5, I can't get my air. If you can check your oxygen sat and it's better than 94%, now this is if you have normally healthy lungs, you're probably okay. But if that's dropping below 94 when you're resting, then that's a worrisome sign.
Right.
And that's when treatment with oxygen is likely to be beneficial. So, we can't treat it with anything else really in the hospital.
Yeah.
So we set you up at home with some oxygen if we can, and keep that SAT above 94%. Now, if you're chronic lung disease, you might want to come in the hospital anyways. I mean, we're going to monitor you closely, but if your SATs are dropping, into the high 80s, probably need to come in at that point.
Yeah. And honestly, if I'm taking a phone call and can't see someone face to face and they're telling me they're short of breath or they feel like they have to work harder to breathe, even if their oxygen saturation is 94%, I would prefer that patient to be seen in person.
Yeah, bring them in and assess them. If they appear to kypnic, breathing fast, then they're headed in the wrong direction. And we know those patients who are hospitalized and require oxygen, that steroids are likely in some of them to be beneficial.
Right.
And that's the only treatment that we know for sure.
Yeah. And so I think a lot of folks' treatment at home A lot of people will feel fatigued and those vague symptoms maybe for days and weeks after their diagnosis. That doesn't necessarily mean you need to be reevaluated in person. It's going to take some patience, but if you're short of breath, then you might want to call in. Yeah.
Yep, short of breath's the problem. Cough is very persistent after this COVID, so I've had patients who recover everything else, but they're still coughing for weeks, and there's nothing we can do. It just takes time.
Yeah, good. What's the most common treatment for cystic fibrosis, and how does COVID affect patients with CF?
So again, cystic fibrosis is an inherited condition where the mucus isn't cleared from the lungs because of a chloride channel deficiency. And so the mucus builds up and causes damage to the airway. And any chronic lung disease is going to increase complications from any infection of the lungs. COVID doesn't seem to be, worse for cystic fibrosis than influenza or other. In fact, influenza is worse because younger people do more poorly with influenza than they do COVID. And so the key treatment for cystic fibrosis is early recognition of the condition and referral to a specialist who takes care of cystic fibrosis. Yeah. So watch for that signs of, salt on the pillow and the things that signal a problem with the chloride channel, and family history. If there was a bunch of people in their 30s and 40s who had chronic bronchitis or died of respiratory problems, then you got to think about that in your offspring.
Yeah.
So recognize it early, get to a specialist.
Yeah, good. All right, one last question. Are there things I can drink to cleanse my lungs, like honey and hot water, etc.?
So that won't cleanse your lungs.
Right.
Nothing's going to cleanse your lungs. There's some of this stuff advertised, air and some of those things, and they won't cleanse your lungs. Now, honey and hot water, honey and tea, great for cough.
Yeah.
As good as any over-the-counter remedy. Vicks on your chest or on the bottom. Patients who come in and want something for their cough, I tell them I really don't have anything better than the lozenge you use at home, unless you have asthma or something else, GERD, heartburn causing your cough. So it's not going to cleanse your lungs, but it might help with your cough.
Yeah, good. And now for the answer to tonight's Prairie Doc quiz question. Smoking is a causative factor in all of the following problems except A, lung cancer, B, COPD or emphysema, C, asthma, or D, heart attack and stroke. The answer is C. While asthma may be adversely affected by smoking, it isn't caused by it. The winner of tonight's quiz is Nick Hess from Lake Hendricks, Minnesota. Thank you, Nick, for participating. A book will be in the mail to you soon. We'll be right back after this.
Extra, extra, read the Prairie Doc Perspectives weekly column in your local newspaper. More than 130 newspapers in the region print the newspaper column written by the Prairie Docs, covering a variety of medical and health-related topics. Ask your local paper if they print Prairie Doc Perspectives.
As a primary care physician, I commonly encounter patients who smoke cigarettes. Most people, including those who smoke, are aware of the long-term health risks posed by smoking. Of course, as a physician who cares about their current and future health, I want these patients to embrace the goal of smoking cessation. As someone who has never been a smoker myself, I admit I cannot fully understand the struggle of this task. However, the data suggests that quitting smoking can be extremely difficult. I find it helpful to understand some basic psychology when it comes to smoking cessation. In the 1970s, a duo of scientists named Prochaska and De Clemente, after studying subjects who smoked and their likelihood of successfully quitting, developed the trans-theoretical model of stages of change. This model is widely used today to assess readiness for change when it comes to smoking and other lifestyle changes such as diet, exercise, alcohol, and other substance use. The following explains each stage and how we can apply them to help with smoking cessation. Pre-contemplative phase. A person has no intention of changing their behavior soon. In this case, I plant the seed by providing some basic education and encouraging the patient to think about it before the next visit. Pushing or forcing change at this stage is not likely to be fruitful. Contemplative phase. A person is thinking about making a change, perhaps in the next 6 months, but they may not be ready for a definitive plan. I offer specific education about quitting and ensure follow-up to help with planning when they are ready. Preparation phase. A person is ready to implement change in the next 30 days. Time to cheer on my patient and set them up for success. We might set a quit date together, consider referral to the quit line, and discuss more specific strategies, including medication or nicotine replacement. Action phase. This is the first 6 months of the big change, during which patients have a high risk of relapse. It is crucial to check in often with me, their quit line counselor, and their other support people. Maintenance phase. After the action phase, risk of relapse decreases but does not go away. I offer my patients a safe place to discuss their urge to smoke and encourage them to stay tobacco-free. If they do slip up, I remind them not to give up. I help them focus on the hard work they've already done and stay successful. Quitting smoking can be difficult, but it is truly one of the best things a person can do for their long-term health. There is support out there, starting with your primary care provider. When you are ready, ask for help. Thanks so much, Dr. Pietila, for volunteering your time to answer questions about lung health. The flu is a common cause of pneumonia, so now is a perfect time to protect yourself by getting a flu shot. And if you're 65 or older, you should get vaccinated against pneumococcal pneumonia, a common form of bacterial pneumonia. If you would like more information about this program or to see and hear more episodes of this program, please like and follow us on Facebook and YouTube or visit us at prairiedoc.org. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever you get your podcasts. That does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
It is a wide open evening. Any disease, any medical question. It is Ask Anything. Next time on Call with the Prairie Doc.
So, Mom, it's 20 years ago now that you and Dad started this idea of evidence-based medical shows for free for everyone. Does that sound right?
That's right. And it was really great that you and your dad were able to create that theme music for us.
Yeah, that was really cool. Making music with Dad, one of the best things. You know, as long as I can remember, you and Dad were pouring your energy and your heart and your soul into the Prairie Doc and into the Healing Words Foundation. And I'm just really proud of you.
It's great to have people of your generation, like our new Prairie Docs, to give us your ideas and to help continue Dad's legacy.
It's our turn to turn to the people out there and say, we need your help. You can support us too. We do this without advertisements from pharmaceutical companies, and we need independent support. So go to prairiedoc.org and make a donation today. And if you don't have money for that, keep coming to see our show. We need your support in other ways. Thanks.
Thanks.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
And with the ongoing support of these individuals and institutions, Brookings Health System, Ophthalmology Limited, South Dakota Academy of Family Physicians, Avera Heart Hospital, Fishback Financial Corporation, South Dakota Foundation for Medical Care, Dakota Allergy and Asthma, Vance Thompson Vision, Black Hills Medical Society, Brookings Madison Flandreau District Medical Society, Sioux Falls District Medical Society, Yankton District Medical Society, Aberdeen District Medical Society, Urology Specialists, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, Lake Poncet Sailing Academy, Aberdeen Asthma and Allergy, Dakota Bank, South Dakota American College of Physicians, and Swiftel Communications.